Hi, I'm Mike Hughes. Welcome to Cladels Medically Speaking. Each month, we'll explore a variety of topics to help you better understand certain medical conditions and treatment options. Today's guest is Dr. Chris Hamill, an orthopedic surgeon specializing in spinal deformities. Dr. Hamill was fellowship trained in pediatric and adult spinal deformities at the Washington University Barnes Hospital in St. Louis, Missouri. Operating at the Buffalo General Medical Center, he has been performing the majority of these complex surgical procedures for over 20 years. Dr. Hamill, thanks for joining us today. Most people have heard the term scoliosis, common term, but explain what it is and why it's considered a severe deformity.
Well, scoliosis is basically a three-dimensional deformity. So we always think in two dimensions, but it's actually a curvature of the spine, but when the spine curves, it actually rotates as well. And that's why it becomes more noticeable in people, is because of the changes in their body, that the way they look, especially in the younger adolescent females and males, you'll see a curvature in their back, and that's how they get diagnosed, usually through school screening. What I have seen in my practice is more of an adult population, and there's two types of scoliosis in adults. There's one that is adolescent scoliosis that starts in the young age and then develops into adult problems, which is usually associated with there's too much stress in the spine, and so everything starts to wear out. The discs start to wear out, the joints start to get bigger, and people present with spinal stenosis. So there's an adolescent idiopathic that has adult changes, and then there's a different type, a second type called de novo scoliosis. And what that is it develops in older age, and that's usually in patients in their 50s or 60s or 70s, even 80s, and the oldest one that I took care of was in their 90s, where they present a little bit different. Their presenting complaints are usually pain, and it usually has some effect on their quality of life. So they can't stand or they can't walk, and that's why they present.
Gotcha. So you talked about the different age ranges and even a little bit of the pain symptoms that kind of present. Is there a specific way that what's the diagnosis? How is it diagnosed?
It's usually diagnosed by a physical exam and then radiographic studies to corroborate that physical exam.
Gotcha. So is that something that people notice that they may be humped over, they're curved a little bit, or is it just you may be at your normal physical and it's pointed out?
Could be both. Could be either. Most commonly, people will notice that they look different in pictures. So they'll have a picture from 5 years ago and then 3 years, and they'll look different in the picture. They'll have lost height. The pants will fit differently. Women say their skirts appear to be uneven. Their waistline is asymmetric, so one side is higher than the other. So it's really a change that occurs, and it's not usually something that you see in the 20s and 30s and 40s. It's more commonly to see in an older population.
So we've talked a little bit about scoliosis. Talk a little bit more about kyphosis. What is that, and how is that diagnosed?
Kyphosis is something that we see in the older population. And what happens is most commonly that everybody says that life is a kyphosing entity. So as we get older, we become more kyphotic, which means we're bent forward more. And there can be exacerbations of that with what we call fractures, senile fractures, meaning that there's no reason for them, and especially in the older osteoporotic population, that's when it's really common.
So there's not so kyphosis mainly related to the older population. Scoliosis could be either.
Usually has two main effects in terms of age. One is in the adolescence, and the other one is middle age.
Talk a little bit about treatments before we even go down the road of surgery. Are there conservative treatments? Are there things that patients can do to be treated for this?
Of course, and I'm always tell my patients that I'm the guy of last resort. So there's lots of different options for treatment. Most of those include physical therapy, chiropractic care, injections, acupuncture, massage. There's lots of different modalities that are effective in the treatment of scoliosis and kyphosis. Everybody gets non-operative treatment. It's pretty much a standard across the industry that if you have scoliosis or you have kyphosis or you have spinal stenosis associated with your scoliosis, so the first line of treatment is really for non-operative management. And that includes physical therapy, injections, something to try to alter your pain level to improve your quality of life. And how much of that occurs and how often you go really depends on how much you're affected by the problem. Some people can't stand for more than 3 or 5 minutes, so physical therapy is not as effective where someone can't participate if they're very debilitated. So it really is on a case-by-case basis.
So talk a little bit more now about surgery. Should those other options not work or they're not as effective, what are the options for surgery?
Well, surgical treatment for scoliosis and kyphosis is usually fairly a significant amount of surgery to correct the problem. It's a very correctable problem, but it just involves a significant amount of treatment to do that. And surgeries can last from anywhere from 3 or 4 hours to 10 or 12 hours, depending on how severe the deformity is. There's such a wide variety of degree of involvement that it makes it difficult to kind of give you one set answer. I think that in terms of outcome, surgery has shown to be very effective for the treatment, but it is a commitment from both the doctor and the patient.
So you're more along the lines of it is so invasive, we really need to focus in on some of those other treatments first before you get to that last resort surgery.
Yes, of course. We want to say that to all my patients is that let's try to get you better without surgery, because if we do, then you're going to be that much better off.
Right.
So,
what about some of the new developments, technology, studies? You've been in the orthopedics for a long time, and you've seen the industry change quite a bit. Talk about what some of the new developments are. What are things coming down the road?
Well, some of the things that are really have been impressive, I think, is the coordination of the team care. I think that's one of the best things that we've shown, especially in our area and at the Buffalo General, is that we have such a great team that does these day in and day out, that it can really be a cooperative effort between myself, between the neurosurgeons, the SICU people, the floor nurses. Everybody's on board with the difficulty and the complexity of these procedures. So I think that's one thing. The other technology, when I started doing this, we used to use a Harrington rod, which was kind of the first generation of instrumentation that we used to fix scoliosis, and now we're on the third generation. So it's been a significant improvement in that. We've come with better technology to treat people. There's work being done now with robots, which is going to have its place eventually. It's still in the nuances of trying to make that work. So it's exciting. People seem to be doing better and better with the procedures, though.
Is there a stigma attached to scoliosis or kyphosis? I mean, do you see people who are afraid of those terms or dealing with this?
We do. We see it both in adolescents and adults. I think that it's always has, if you have scoliosis, you have some type of disability, but it's not true at all. I mean, there's professional golfers that have scoliosis. In fact, I have a young man who's 20, I think he's 24, 25 years old, who had surgery about 6 or 7 years ago, who's a professional power lifter. And he can actually deadlift 555 pounds.
Wow.
You can actually watch the bar bend when he lifts that much weight. It's pretty interesting.
So you've seen the industry change, progress. Your focus is much more on a less invasive style first. You want to make sure that there's not a stigma attached to that. So your advice for those who may think they have this, or family members dealing with this with either their elderly or their children, is it, go see your primary care doctor? How do you make sure you take that first step?
Yeah, I mean, I would go see your primary care doctor to see, what your symptoms are, what problems that you're having. Is it scoliosis? Is it symptoms associated with your scoliosis, such as spinal stenosis, A lot of the people present with what we call neurogenic claudication, which is when they walk, their legs start to feel heavy, or they can't move as they used to. I always make a joke when I see people at the grocery store that lean on the cart. They're usually suffering from spinal stenosis. Do they have scoliosis or not? I don't know, but I'm going to start handing my cart out at Wegmans.
Obviously, you're very busy with your practice. How can someone get a hold of you should they need your assistance, your office assistance?
I'm on the UB Orthopedics website. You can reach my office at 204-0487. I'm always happy to see people.
Great. Dr. Hamill, thanks for joining us today.
Thank you, Mike.
I'm your host, Mike Hughes. Join us again next time on Medically Speaking.